Awesome. Thank you and good evening to everybody here. My name is Roselyn Cendeño Dávila and I am a huge advocate of reproductive mental health. Why? Because postpartum depression constitutes a major public health problem with serious consequences, not only to mothers, but to families and also to the emotional, physical, and cognitive development of the children. So what do we know about postpartum depression? So we know that it's a serious disorder that can be experienced by up to 1 in 7 women. The Diagnostic and Statistical Manual of Mental Disorders does not offer a diagnosis of PPD. Instead, it's discussed as a major depressive disorder specified under peripartum onset. What does that mean? That means that to meet the diagnosis criteria for MDD with peripartum onset, symptoms must be present during pregnancy or in the next following 4 weeks after delivery. So studies have shown that the postpartum period presents neuroendocrine alterations in addition to poor social support, marital conflict, low income, and maternal age. PPD is the leading cause of non-obstetric hospitalizations among women ages 18 to 44. 50% of PPD goes undetected, and about 1 in 5 women are not asked about depression during a prenatal visit. PPD symptoms can appear not only within days, but months after delivering a baby. The CDC has presented some information about the incidences of PPD. As you can see, there's not a lot of information about the state of Texas, but there's some information out there. So the American College of Obstetricians and Gynecologists, they recommend 7 screening tests for PPD. All of them, they have been validated. But the most common screening tool for PPD is a 10-item self-administered questionnaire known as the Edinburgh Postnatal Depression Scale. There are some interventions out there that include pharmacology, supported interpersonal and cognitive therapy, psychosocial support, and complementary therapies. But what have we learned about PPD after COVID? That there is still a need for consensus on the ideal time to conduct screening for PPD, that resources are addressing PPD does not always reflect the needs of pregnant women and new mothers, and also that in a health crisis, there must be a reproductive health policy agenda to prevent depression, suicide, domestic violence. So in a study that I conducted recently with low-income women, some of those findings included that low-income women interviewed did not receive sensitive mental health screening to be diagnosed and provided with mental health resources. Participants in the study interviewed, they were Medicaid and or WIC beneficiaries, which may indicate disparities among women who are not privately insured. Symptoms experienced by participants included sadness, mood swings, inability to sleep, fear, difficulty remember, concentrating, lasting several months, which, if screened, will have met the diagnosis criteria for major depressive disorder under peripartum onset. And the study also was able to find that low-income women, due to the uncertainty about the diagnosing and treatment process, may not disclose PPD symptoms. Why would I say something and I fear that my children will be taken away from me? Or why would I say something if I don't know what kind of treatments or resources will be provided? Also, the participants mentioned the lack of support from health providers and family members left them feeling isolated and believing that they have to deal with these symptoms on their own. During the pandemic also, doctors' appointments, they were brief, they turned into virtual phone visits, reducing participants' opportunities to speak up. Some participants, they missed postpartum doctor's visit due to the lack of insurance coverage. And low-income interview were not only not insured, but also they were the only caregiver of their children during the pandemic, preventing them from finding the time to seek the help needed. Some participants also found some resources on their own that were not for mental health. So after all these, participants were very clear about what do low-income families feel that they need. They mentioned that screening for PPD beyond the first visit postpartum is much needed since there's so much going on at that time. That face-to-face visits to discuss mental symptoms rather than a questionnaire that I have to complete on my own and that I don't know if someone will really look through it is very needed. Education, patient education on PPD, even if the patient is not disclosing symptoms, is very needed. That having a case manager following up with moms to check on them. The need for free programs for postpartum depression for women who lose coverage after delivery, which typically happens right after delivering a baby. The use of social media to spread awareness and share resources for postpartum depression. And also the need for postpartum depression awareness for families and partners to break communication barriers. Like I said earlier, I'm a huge advocate of reproductive mental health. In the state of Texas, where reproductive law has changed, I feel that, and participants also feel, like there's a huge need for us to advocate for the mental health resources that we need so that families don't have to get into the journey of parenthood and struggling with mental health illnesses on their own. Thank you.